Welcome to this series of lectures in oral medicine, this one entitled Salivary Gland Disease 2. So we have already discussed the headings under blue in this slide, and we are going to be talking mainly on neoplasia, mainly salivary gland tumours. So the WHO classification of salivary gland tumours is split into adenomas, which are the benign tumours, and carcinomas, which the most common adenoma is pleomorphic adenoma. And then under that classification, they also have non-epithelial tumours and malignant lymphomas, which we won't be covering within the scope of this lectures. And then you have tumour-like lesions. These are not neoplasms, and some of these we will discuss, and some of them we have actually already touched on. Some of the cell types that occur in salivary glands are myepithelial cells, which is a hybrid of epithelial and mesenchymal structural and functional phenotype. They can be neoplastically modified myepithelial cells, which can occur in a variety of salivary gland neoplasms, including pleomorphic adenoma, myepithelioma, adenoid cystic carcinoma, myepithelial carcinoma, and polymorphous low-grade adenocarcinoma. Other cell types that can occur in some of these tumours are clear cells, clear because due to their sparsity of organelles or storage of cytoplasmic contents like glycogen, mucus, lipid. So these cells appear under histopathology to be clear, almost like a fat cell. And these can occur in pleomorphic adenoma and clear cell oncocytoma, both of which are benign tumours. Duct cells are cellular elements of adenomas, so pleomorphic Wharton's tumours or oncocytoma may have duct-like areas, and some carcinomas such as acinic cell, mucoepidermoid, and myepithelial carcinoma, as well as SCC, can show duct-like cells. This is SCC associated with salivary glands. Basal cells are characterized by cell types in basal cell adenomas, basal cell adenocarcinoma, and solid type of adenoid cystic carcinoma. So they're the four types of cells that can generally occur in salivary gland tumours and help with the diagnosis. So further help with the diagnosis may be through immunohistochemistry, where we stain the tissue with certain markers, such as cytokeratin and epithelial membrane antigen and carcinoembryonic antigen and amylase, for review of acinic cells in the tumours. Duct cells can be stained with cytokeratin, EMA, tissue peptide antigen, CEA, and lactoferrin, and myepithelial cells can be stained with S100 protein, actin, and myosin. About 0.1% of all tumours, excluding skin, are salivary gland tumours, and the majority of these occur in the parotid glands. Sublingual glands are rare, and there's an association with breast carcinoma and radiotherapy. So those people that have had breast carcinoma and radiotherapy are probably, possibly, more likely to get a salivary gland tumour. Major glands, of the major glands, 50 to 60% are pleomorphic adenomas, 5% mucoepidermoid, and 5% adenoid cystic. Of the minor gland tumours, 15 to 20% are of all salivary glands salivary gland tumours occur in the minor glands, and 55% of these occur in the palate, 15% in the lip, mainly upper lip. Intraosseous tumours are rare, and 60% of minor salivary gland tumours are pleomorphic adenomas, 25% mucoepidermoid, 15 to 25 adenoid cystic. So general structure of pleomorphic adenoma. Pleomorphic, by its definition, shows variable architecture and consists of mucoid, chondroid, hyalinoid, and myxoid areas within the tumour tissue, and there's usually a capsule, and it's slow growing. So those are the major components that help with the diagnosis. Adenoid cystic carcinoma have a infiltrative nature of perineural and perivascular, and spread can occur even years after excision, so even 10 years. So these patients need to be followed up. Mucoepidermoid carcinoma is characterized by the presence of squamous cell, mucus-producing cells, which stain with PAS. PAS incidentally also stains Candida, and it stains these mucus cells a magenta color. And there may also be some intermediate type cells within the mucoepidermal carcinoma. And the overall 5-year survival rate is about 70%, and there are low and high grade mucoepidermoid carcinomas, and the low grade ones have a greater survival rate. Polymorphous low grade adenocarcinoma, they are cytologically uniform but morphologically diverse, hence polymorphous, and has a low metastatic potential. Now, if we look at some other salivary gland swellings that can, or associated swellings, necrotizing cytometaplasia, which clinically can look like a carcinoma, a slow easing deep ulcer, or erythematous nodule. Usually mean age around about 50 years with a male predominance, and it heals spontaneously within 4 to 10 weeks. But as mentioned, it can look like a tumour, but it is a benign condition. And under histopathology, what you see is squamous metaplasia, these islands of squamous epithelium, and because there are those islands, it stimulates malignancy, especially a squamous cell carcinoma or a mucoepidermoid carcinoma. Wegener's granulomatosis causes necrosis and granulomatous inflammation, as well as vasculitis, triad of those three things, and can affect the upper respiratory system, pulmonary, renal, and salivary gland involvement is possible, but it's usually rare. And oral manifestation, usually you get oral ulceration and these so-called strawberry gum pattern of the gingiva. Perforation of the palate may be a possibility, and swelling and desquamation of the lips, and major salivary gland involvement can be a feature. Microscopically, again, what you get is a granulomatous pattern, where again they're non-caseating granulomas with giant cells, multinucleated cells that are strewn throughout the tissue. There may be some areas of fibrosis as seen here. Investigations for Wegener's granulomatosis, you might do a sinus and chest radiographs, ESR or C-reactive protein, which is an inflammatory marker, renal function test, anti-neutrophil cytoplasmic antibodies, and 100% with widespread disease, they'll be present, but 65% with limited disease may show the presence of cyclic ANCA. Siloliths are calcified structures that develop within the salivary gland ductal system, and it's due to the deposition of calcium salts around nidus of debris. Nidus of debris might be mucus bacteria or duct epithelial cells or foreign bodies, and it's usually unilateral, painful, intermittent swelling, and these swellings occur more at meal times, and then they will go down. It may be seen on radiographs, not always, but multiple stones in parotid may give the appearance like calcified parotid lymph nodes, as can occur in TB, tuberculosis. Usual treatment is to try and milk out, but if they're large, then surgery may need to be carried out. Siluria is overproduction of saliva. This is rare, can occur in maybe the result of local causes such as recurrent stomatitis or ill-fitting dentures. Episodic hypersecretion, which is a water brash, may occur as a protective buffering to neutralize stomach acid in the situation where patients have got GI gastrointestinal reflux. Siluria is a clinical feature of rabies and heavy metal poisoning, and may also occur in conditions such as neuromuscular disorders, Parkinson's or cerebral palsy, but this is generally in these people it's because of lack of control rather than increased saliva flow. Xerostomia is a clinical term for the feeling of dry mouth. So it's a subjective feeling, and it can be caused by hypersalivation or dysesthesia. The causes of hypersalivation is iatrogenic, mainly drugs, radiation, or graft versus host disease, and certain diseases that affect the salivary gland, some of which we've discussed already: Sjogren's syndrome, HIV, salivary gland sarcoidosis, salivary gland aplasia, and hepatitis C and viral infection. Dehydration, severe diabetics and other runners, long distance runners, but this is only usually a short-lived hypersalivation. Sometimes psychogenic cause can be attributed to xerostomia. An example of this could be anxiety when you're getting up to give a talk in front of a big audience. Sometimes your mouth becomes dry. That's a physiological thing, and it's usually short-lived. Complications of hyposalivation: dental caries, periodontal disease, candidosis, and bacterial silodinitis. Diagnosis usually with saliva flow rate. Unstimulated saliva normally is 0.3 mils per minute, and if it's less than that, then it's abnormal. Labial salivary gland biopsy, as well as blood tests, which would include anti-Sjogren's syndrome antibodies, and salivary gland imaging as well, mainly MRI, sclerography. Sometimes ultrasound may be useful. Management involves management of the side effects or the effects of hypersalivation, so management of caries, periodontal inflammation, with the use of topical fluorides, chlorhexidine, and use of certain materials such as glass ionomer rather than composite materials, and good oral hygiene instructions. Management of underlying or associated conditions such as diabetes or dehydration. Local topical stimulants and lubricants, saliva products, some of the biotin or GC products, artificial saliva, and maybe sometimes some of these patients may be given something like pilocarpine, which is a parasympathomimetic drug, to increase the production of saliva. Acupuncture has been shown in some cases to be effective, and in the future novel therapies such as gene therapy may be a possibility. There is also a PDF document called Salivary Gland Dysfunction that you may like to review to complete your studies on salivary gland disease. Thank you.